Hello again, and welcome back to the Oncology Brothers podcast. I'm Rohit Gosain. I'm here with my brother and co-host Rahul Gosain. Previously, we have covered diffuse large B-cell lymphoma with Dr. Carla Casulo from Wilmot Cancer Institute. Today, we are switching gears to low-grade lymphoma, that is follicular and mantle cell lymphoma. To cover all this, I am excited to welcome a friend, colleague, and my mentor during my fellowship days, Dr. Pallawi Torka from Memorial Sloan Kettering Cancer Center. One lie, Pallavi. It does feel odd asking you questions because in fellowship days, it was the other way around. Well, let's get started, Pallavi. Thank you so much for joining us.
It's my pleasure to be here. You always ask great questions as a fellow, and I'm sure you're going to ask very insightful questions today.
Thank you.
Pallavi, welcome. We have a lot to cover. We're trying to cover follicular lymphoma and mantle cell lymphoma in a short period of time, so let's dive right into this. Starting off with follicular lymphoma. Pallavi, when you're seeing a patient in your clinic, what is the bare minimum workup that you need when it comes to this and planning your treatment? Is it PET CT, core biopsy? Do we need bone marrow biopsy in everyone? Do you look for NGS? What does it really look like in your clinical practice today?
Yeah, that's a great question. I typically start with, first of all, a good history and physical because the presence or absence of symptoms is very important in decision making. Um, you, of course, need some basic blood work, CBC, CMP, because you want to see if the patient has cytopenias. I have moved away from doing bone marrow biopsies as a routine if a patient does not have cytopenias. I do tend to check a peripheral blood flow cytometry to see if there is some minute amount of follicular lymphoma floating around and use that in my treatment decision making. But of course, the most important test is imaging. Traditionally in the guidelines, it says you could do either a CT or PET, but I've started to do just PET scans because it is very important in every patient with follicular lymphoma to rule out transformed disease, which, as you know, is treated very differently. So it's just, if I do a PET scan, I get all my answers from that one scan.
Pallavi, follicular lymphoma in general is an indolent disease with overall survival ranging from close to about 20 years or even more at times, but unfortunately, it is incurable. So in community, we are very much aware when to treat these patients. That is based on GELF criteria, but the confusion comes about what to treat them with. So if you don't mind going over your frontline treatment options from stage 1 to stage 4 for this particular disease type.
I usually put patients in their disease in four buckets. First one is low burden asymptomatic, which is what we usually tend to just observe. And by time, because as you know, the treatments are just improving by leaps and bounds every day. So the more they wait, the better chance that they would get something even better in the future. Then, of course, there is the high burden, high symptom disease patient, and of course, they need treatment. So the GELF criteria, as you mentioned, is the bucket which is no symptoms or low symptoms, but a high burden of disease, which is treatment. And then the hardest patient to treat is the one which has very minimal disease, but the patient has a lot of constitutional symptoms. So in that patient, that is as you see in the algorithm, it says there symptomatic and low burden disease. That's where I tend to use single agent rituximab with the caveat that I tell the patients, hey, listen, we're going to try this treatment. It's going to shrink your cancer, but I'm not really sure if it will treat your symptoms. Let's just try and figure this out. And usually I use just weekly rituximab for 4 doses in that case, and that should be enough to alleviate any symptoms. So coming to the bread and butter of it, treatment wise, which is, high burden disease, in that case, I usually take the patient's fitness in account when I decide treatment. Our options in frontline include chemoimmunotherapy, so rituximab, bendamustine, or rituximab CHOP. The gallium study also evaluated obinutuzumab with bendamustine, CHOP, or CVP, and there was a progression-free survival advantage, but I'll get to the nuances of that later. The other option is R square, so rituximab and lenalidomide, and the third option is single agent rituximab. So if somebody is really old and frail, then I would use single agent rituximab, but I don't really like using single agent rituximab as much because the complete remission rates are low with that. So you might buy a little bit of time, but the patient is probably looking at treatment again in a few years and they're going to be older at that time. So really not worth your while. So in that case, my favorite options are either rituximab and lenalidomide, which is about a year of treatment, versus low dose BR. So, rituximab, as you know, is very well tolerated. And for patients above 75, you can do bendamustine 70 milligram per meter square on 2 days rather than, the full 90 milligram per meter square. If you are even more worried about the patient, the other thing is what you could do is 50% dose reduction. So instead of coming on 2 days, the patient could just get 90 milligram per meter square just on day one. So you get that nice balance between efficacy and safety with that. But for most patients, like I mentioned, if they're fit and you really want to hit the follicular lymphoma hard, get a high complete response rate, my preferred option is rituximab and bendamustine in those patients.
Wow, there's a lot here. Pallavi, thank you so
Sorry.
much for. No, 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 no. This is great. This is exactly what we're looking for. These treatment options that are available. Pallavi, thanks for going over that. When we were covering the initial frontline treatment, you alluded to the nuance of PFS when it comes to picking the right anti-CD20, be it Obin or rituximab. With Primo trial, also with the maintenance, we've seen PFS, no clear OS. Can you touch on this? The right anti-CD20, in what scenarios are you considering rituximab maintenance when we know there's no clear OS here?
Yeah, and it is very interesting that if you talk to like five lymphoma doctors, you'll get 15 different answers.
Exactly.
So in my mind, if a drug has just progression-free survival benefit, you need to really pick it for the right patient. So what do I mean by that? Obinutuzumab is definitely a more powerful anti-CD20 monoclonal antibody, but it does cause more cytopenias, more infusion reactions, and increased chance of viral infections. I've had patients who were on Obin maintenance and they died of COVID even after 2 years, stopping maintenance for 2 years just because they had no B cell immunity. Um, Having said that, in patients who are high risk, meaning let's say they had leukemic phase follicular lymphoma or their Ki67 was really high, uh, patients like that, it might be worthwhile to give obinutuzumab rather than rituximab upfront. The other thing that you could do is give them CVP rather than bendamustine, just in case you're suspecting that there might be some occult transformed disease that you've not been able to really prove. Maintenance, I generally don't do, whether it be rituximab or obinutuzumab. I might do it for that rare patient who's 85 and you feel like you never ever want them to see treatment again. And even a few years of PFS benefit is worth their while. But that's not my favorite strategy, especially since the past 3-4 years where I've seen patients really suffer from COVID and other respiratory illnesses if they were on maintenance.
Absolutely. Again, there are serious long-term side effects to these medications. Pallavi, thank you for touching on that. Now, let's talk about relapse or refractory follicular lymphoma. Second line space for lymphoma, thankfully, is starting to get really crowded. We have few CAR T cell options, BiTEs, EZH2 inhibitors, transplant. Your thoughts here?
Yes. So, I'm looking at this algorithm, and it is true that in terms of approval, for second line, we have R square if you use chemotherapy upfront. And if you use R square upfront, you could do rituximab, bendamustine, or R-CHOP. And if you use either of them, you could use the second agent. For example, if you did BR, you could do R-CHOP in second line. And then the other approval in second line is for tazemetostat, which is, as you pointed out, not dependent on the EZH2 mutational status. But the most powerful agents that we have are in the third line, bispecific antibodies and CAR T cell therapy. So, what I have done most recently is I have treated most patients first line with chemoimmunotherapy, second line with R square, and then moved quickly to either a bispecific antibody or CAR T cell therapy. I really haven't sent any patients for chemo followed by auto transplant in the past five years or so. Since R square came, we have not really needed to invoke that. Because if you think about it, um, high dose chemotherapy followed by auto transplant was for patients who have early progression of disease, and I'm sure you're going to bring that up, is progression of disease within 24 months. But now we know that most of these patients actually do not have follicular lymphoma, they actually have transformed disease, and maybe they're better served by CAR T cell therapy anyway. um, and again, if they have aggressive follicular lymphoma, then again they're better served by CAR T cell rather than auto transplant. So really, that treatment paradigm is going away for most patients.
Now, in community, though, we are not giving CAR T yet, but we have to talk to these patients or at least get them prepped up to what that visit at tertiary care center is going to look like. So, when patients are asking about CAR T, BITE, or EZH2 inhibitor, what does in general response rate and survival looks like here?
So EZH2 inhibitors, tazemetostat, that was the one that got approved first. So let me talk about that. Super well tolerated. Although the pill burden is high, it's 4 pills in the morning and 4 pills in the evening, some diarrhea, but again, it's very easy. The progression free survival, as far as I can remember, is less than just shy of a year or about a year.
Okay.
So it is a great option for someone who has something else going on in their life and they just don't want to be bothered by
Right.
by coming in for infusions and such. So I think that's a great idea, but again, not like that drug leads to very few long-term responses, so it's more of a bridge of sorts. um, for bispecific antibodies, I think that's my number one choice in this setting, because both epcoritamab and mosunetuzumab are now available in subcutaneous formulations. So it's really, you do have to come in a little more frequently initially, but then later it becomes every 4 weeks for epcoritamab and every 3 weeks for 3 to 4 weeks for mosunetuzumab. Quick subcu injection and they leave. So I think there is some risk of CRS and neurotoxicity with the first cycle, which, I think it's a great opportunity for community to partner with academia to get the patient started on this treatment in a controlled setting. But after that, they're all yours. It's very easy to deliver in that setting. And the good news is that mosunetuzumab is time-limited treatment, so it's 1 year and done. There is emerging data for retreatment, so that remains to be seen, but it is a possibility that you could retreat those patients too. CAR T cell therapy is a totally different ball game, as you said. Advantage is it's one and done, but it needs a lot of coordination and just takes more logistically from both the physician and the patient. I think it is my preferred option for that young patient who has really high risk disease. Let's say you gave BR, cancer came back in a year. You gave R square, cancer came back in a year. This is the patient who really needs something more sustainable. So CAR T would be a good option there.
There is another big topic in hand here. So switching gears to mantle cell lymphoma. We know there are different types, nodal, extranodal. And then, of course, we also have to keep things in mind, Ki67, TP53 mutation, SOX11. There's a lot going on here. Pallavi, when it comes to mantle cell lymphoma, be it BTK inhibitors, who should get transplant, can you walk us through your initial treatment paradigm for newly diagnosed mantle cell lymphoma here?
Yeah, absolutely. And it's all good news, like the
Yes.
treatments are getting better and better. So that's great. Um, so I so there most patients with mantle cell lymphoma have nodal disease, and most of them have stage 3 or 4 disease. It's very rare for us to get patients who have leukemic phase indolent mantle cell lymphoma. And that's the patient, basically, you think the patient has CLL, but when the flow cytometry comes back and you get cytogenetics, it's like, oops, it's mantle cell lymphoma. In those patients, observation is recommended if they don't have any cytopenias and such. You really don't need a bone marrow biopsy. You can just make the diagnosis of peripheral blood in those patients. uh, if a patient has nodal disease, you need that lymph node biopsy, of course. Again, core biopsy is okay. What you're specifically looking for is the Ki67 on that biopsy. If somebody has less than 10% Ki67 staining, then it's low risk for sure. More than 30% is high risk for sure. 10 to 30% is a gray zone. You look at the patient and you decide where you want to classify them. Low burden disease, patient is asymptomatic. Most of the times patient had a colonoscopy and there was a polyp, and the polyp showed mantle cell. and the patient is in your office. Those patients can be safely monitored. I have some patients who have been under surveillance for years without requiring any treatment. Um, for the other patients, you're going to do a PET scan. You're going to look at the burden of disease. I think in this day and age, we should definitely send the sample for next gen sequencing to look for TP53 mutation. But in most patients who have an intact TP53 and they're in need for treatment, you basically decide whether, we used to say transplant eligible or transplant ineligible, but we have changed that wording and we just use candidate for high dose cytarabine based therapy and frail, unfit patients who are not candidates for high dose therapy. For the longest time, the paradigm was you do consolidation with auto transplant, followed by maintenance rituximab for 3 years. And maintenance rituximab portion is very important for mantle cell lymphoma. This is very different from follicular lymphoma that we talked about. Why? Because there was a study called the Lima study, which showed an overall survival benefit of maintenance rituximab. And also, maintenance is for 3 years here rather than the 2 years which we use for other lymphomas. So anyway, that was the paradigm for the longest time, but our world was shaken last year when the triangle study was reported, where addition of ibrutinib to induction and then to maintenance showed outcomes that were similar to doing transplant. Whether doing both is better than either, we don't know. That data is not mature, but it looks like if you incorporate ibrutinib upfront, you can get away without doing a transplant, which is great news because transplant has its own toxicities, and as you can't do it in community, you have to send the patient somewhere else. What are the problems with incorporating that? Ibrutinib is not our favorite drug anymore because of all, all the side effects we know about, AFib, risk of bleeding and such. So I think it's safe to use the same data, but use acalabrutinib or zanubrutinib instead. The other thing is at MSK, for example, we use DHACs, which is basically swapping cisplatin with oxaliplatin, and we use 4 cycles of that straight up. You cannot really incorporate ibrutinib with DHACs portion. You have to reserve it for either the BR portion or the RCHOP portion. So you don't use that in induction. We feel like the value of BTK inhibitors is mostly in maintenance. So that's where we incorporate that, and we just we remove the transplant from that situation. So in 2024, I would say cytarabine-based therapy followed by maintenance rituximab with BTK inhibitor is the treatment of choice for fit patients. For unfit patients, it's simpler. I think the favorite regimen for most people is bendamustine rituximab for 6 cycles followed by maintenance rituximab for 2 years.
Thanks for covering that. Before we dive into the TP53 aberrations, just want to recap a couple of things here. As you mentioned, it is important to know that the maintenance year for rituximab is based on Lima trial, which is for 3 years, but there is overall survival advantage, while comparison to follicular, there was only PFS. When talking about the BTK inhibitor, when you're utilizing zanubrutinib or acalabrutinib, if the patient has not undergone transplant, say for example, rather an unfit patient, are you considering BTK inhibitors in those settings at all?
So that is an excellent question. And there was a trial that was just reported called the ECHO study at the European Hematology Association conference this year, where they did exactly that. Is they gave bendamustine rituximab with acalabrutinib, and then they continued acalabrutinib and rituximab for 2 years and acalabrutinib till progression. And there was a progression-free survival benefit of doing that compared to just BR alone, but there was no overall survival benefit. And honestly, the progression-free survival benefit was about 15 months. If you just use acalabrutinib in second line for a patient who has disease relapse, the progression-free survival benefit is 20 months. So by adding that up front, you're not really, you're giving it to everybody, you're giving that toxicity, and you're not really helping, I feel like, that much. So I have not adopted it in my practice. Again, if it gets approved by FDA and it's in the NCCN guidelines, I would discuss it with my patients, but probably reserve it for like a very high risk disease patient.
Sounds good. And when considering for fit patients, when you're saying that the transplant is questionable now, especially with the consolidation and maintenance of BTK inhibitors. Now, where are you reserving transplant at least for now? Are you utilizing it for all your fit patients, or just having a conversation and deciding if it's either needed at this point or not?
We're not doing transplant anymore because we're just incorporating BTK inhibitor. If insurance gives you trouble because, technically this regimen is not approved by FDA, it is in the NCCN guidelines, so that helps.
Right.
But if insurance gives you trouble, then of course
Okay.
transplant is the way to go.
Sounds good. Now, talking about this huge aspect of TP53, wherever you see this, whether expression, mutation, deletion, it's always bad, bad, bad. So, how are you deciding or making your treatment decision based on this information now?
Yeah, so previously we just used to use chemo and hope for the best because we had no better tools. And, ibrutinib, even CAR T cell therapy has not been able to overcome the adverse prognosis. So we just didn't know what to do. But in the past year, we have two data sets. One was a study called Simpatico study, where they looked at the combination of ibrutinib and venetoclax. And the other one was data from MSK called the Bowen study, where they looked at zanubrutinib, venetoclax, and obinutuzumab. So basically add a CD20 on top of BTK inhibitor and ven combo. The data is just so good. The overall response rates are close to 100%. The complete response rates are close to 80%. And the 2-year progress, 2 out of 3 patients are still in remission at 2 years, which is almost unheard of in patients with this disease. Just because of this, data is very prelim. We're talking about less than 100 patients, but I think it's enough to change treatment paradigm for this disease, and that's what we need to try and get insurance approval for. If insurance for some reason does not approve a triplet, then go for just BTK plus ven combo, which is actually approved in some other countries. If even that's not possible, then try to do BR and add the acalabrutinib or the echo trial. The bottom line is basically add some novel agent and try to stay away from chemotherapy in these patients.
Pallavi, can I touch a little more on venetoclax? As we worry about TLS when it comes to CLL and you're using this, is that the same worry that you have to have when you're putting these patients on venetoclax and step-up dosing, or what does that look like?
So in the trials, they're still using that same paradigm, but we haven't seen rates like that. I mean, so we don't really know if we need to do it or not because we've just been doing it based on the CLL label, but the incidence of TLS is much lower. Also, in these trials, venetoclax is introduced after 2 cycles of BTK inhibitor and CD20. So your patients already have their disease has been debugged by then. So really, that's how we're managing TLS in this situation.
Absolutely. All right, so we've touched on BTK inhibitors. Zanubrutinib got approved in this space as well. We also have, of course, CAR T here. Pallavi, can you touch on the relapse refractory treatment options for mantle cell lymphoma?
Yeah, so actually relapse is fairly straightforward compared to follicular lymphoma, mantle cell lymphoma. The path is tried and tested. I would say first relapse, BTK inhibitor, BTK inhibitor, BTK inhibitor. And your choices are second gen at this point. So acalabrutinib and zanubrutinib. There are trials ongoing to look at pirtobrutinib in this space. So that remains to be seen. With these drugs, you may have sustained responses, but the average progression-free survival is less than like 1.5 to 2 years. So you should probably prep your patient for third line, like just put that in their mind already. And third line, we have pirtobrutinib, we have CAR T cell therapy, and we have a bunch of other non-FDA approved options that we'll talk about. Pirtobrutinib, the median progression-free survival was of only 5 months in patients who had BTK inhibitor progression. So it's mostly used as a bridge or in that frail patient where you cannot do CAR T. But most patients should be referred for CAR T cell therapy in the third line setting. Among the two products, Brexucell had very high rates of neurotoxicity. So that was a problem. But now with the approval of Lesocell, I think more patients are going to be candidates for CAR T cell therapy now. So that would be preferred. Glofitamab is showing real promise in this space too. So that might be another option for us in the near future. I have used venetoclax in this space. I have used R square, rituximab, lenalidomide in this space. I have used R back 500, and they all work for a while. So these are all options, but I think the other options that I just mentioned are number one, and these are like number two, three, four.
And would you rely on these before switching to CAR T, or if the patient is fit enough, just go for CAR T and
Just
be
go
done
for
with?
CAR T. Just go for CAR T. Mantle cell lymphoma is not a very forgiving illness like follicular lymphoma. You really need to get them sustained PFS 1, PFS 2, PFS 3. Just use the best agents upfront.
Well, thank you, Pallavi. I can't believe you've touched on current treatment landscape for follicular and mantle in such a short period of time. Dr. Torka, thank you so much for taking the time to reiterate the current standard of care treatment options for our community oncologists. For our listeners, let us go over a quick recap from key points from this discussion today.
In today's discussion with Dr. Torka from Memorial Sloan Kettering Cancer Center, we've covered the current treatment landscape of follicular and mantle cell lymphoma. We had a chance to focus on treatment options in first line, including chemoimmunotherapy for follicular lymphoma and the increasing role of BTK inhibitors for mantle cell lymphoma.
For relapsed refractory disease, focus was on growing options of CAR T, BiTE therapy, and transplant. However, we have to balance the side effects that come along with each of these treatment options and benefit that we hope to achieve for our patients. Thanks for joining us. Stay tuned for more discussions around the current standard of care options and practice changing data. We are the Oncology Brothers.